So I'll be talking about stage-based management approach and some real-world data on mucormycosis. This we published in February this year. This was a collection of just 6 cases from Hyderabad and Mumbai. We thought that was a bit too many at that time, but we never thought that we would see 12,000 cases from March 2021. That is the entire Indian data. Looking at what is published, some of the meta-analysis, we find these are the risk factors associated with mucor and COVID. Diabetes, use of corticosteroids, use of tocilizumab, elderly individuals who had severe COVID infection, mechanical ventilation, and prolonged supplemental oxygen. Of course, India is the diabetes capital of the world, and mucormycosis is 80 times higher in India, even in the pre-COVID-19 era. But what makes COVID special is that there is loss of mucosal immunity in the point of entry and point of proliferation. And it is the same route that mucor also follows. And this mucosal immunity remains impaired for a very prolonged period of time. Mucor is everywhere. As we breathe, as we speak, we are inhaling mucor. That is an exogenous source. But apart from that, mucor also happens to be a commensal in the nasopharynx and PNS. So in a predisposed individual with loss of mucosal immunity, these commensals can take over and grow. Recently, we completed the analysis of 2,826 cases from 108 centers in India. And we found that we had a slight higher predisposition for younger individuals. In fact, the peak was slightly towards the, I would say, left, because younger individuals were found to have higher incidence here with a mean age of 53 years, whereas pre-COVID era, this was much higher. And also we found that the peak of onset of first symptom was on the 14th day, which means, and many of these were hospitalized patients, majority of them, which means that knowing the incubation period of mucormycosis, this was acquired while the patient was admitted in the hospital. And of course, there was prolonged onset as well, more than 3 weeks in 16% of patients, more than 2 weeks in 44% of patients. So the peak onset of symptom of mucormycosis was in the middle of their COVID disease. Surprisingly, 23% were non-diabetics and 21% had received no corticosteroids. Only 2% had received tocilizumab. And we found that about 20% of patients were non-hospitalized and they did not receive steroids as well. So there were a bunch of patients who were young, who were home cared with minimal or no steroids. And these were the symptoms and signs. Surprisingly, not surprisingly, orbital and facial pain, orbital and facial edema predominated. And you can see most of these symptoms are ophthalmic, ptosis, loss of vision, and even in other symptoms, proptosis, diplopia, orbital and facial discoloration. All these are related to ophthalmology, and the signs mirror the symptoms. So why do we have to stage the disease? Because we know that the disease starts initially in the nose, paranasal sinuses, and then gets into the orbit and finally into the brain. That is a sequence of events. And some of these, of course, bypass the regular channels and can be non-contiguous and can be through vascular channels as well. But the classic way of transmission of the disease and progression of the disease is what we have taken into consideration to stage it. Now, stage 1 is predominantly in the nasal mucosa, where the first part to get affected is supposed to be the middle turbinate, which manifests as the first MRI sign as black turbinate or non-contrast enhancing turbinate. If you do MRI at that stage, you might find less enhancement or relatively less enhancement of the nasal mucosa as compared to the other side. And blackening of the nasal mucosa and the turbinate can be a little later sign. The patient at this point in time will have nasal stuffiness, blockage, and a blackish or a blood-tint discharge. In stage 2, there is involvement of the paranasal sinuses, where if only ethmoid sinus or one sinus is involved, that is stage 2A. If there are two sinuses involved, like here, you have ethmoid and as well as maxillary sinus. And you also see that this is the infraorbital nerve. Around that, there is a lesion that gives one of the early symptoms of hyperesthesia of the cheek area. Patients can complain of that, and that is one of the currently considered as one of the early signs. And you can see black turbinate here as well. And if the disease progresses to involve the palate, etc., then that is stage 2C. And if bilateral paranasal sinus involvement, that we consider 2D. In the orbit, if it goes through the nasolacrimal duct to the medial orbit where the vision is unaffected, that is 3A. The first radiological MRI sign in the orbit is supposed to be a thickening of the medial rectus muscle or a haziness around the medial rectus muscle, because if the lesion goes through the nasolacrimal duct into inframedial orbit, that can very quickly reach the medial orbit, or if it goes trans-ethmoidally through the lamina baptizer of ethmoid, again it goes to the medial orbit. So inflammation around the medial rectus is supposed to be one of the early signs. Restricted motility can also result because of infiltration around the muscle, and sometimes the lesion can be grossly mechanically restrict the ocular motility. When multiple sinuses are involved, more than one, and also if there is a area of the orbit that is involved beyond one quadrant, then that is 3B. 3C is when there is ophthalmoplegia because of superior orbital fissure involvement or orbital apex involvement. Some of these patients have direct fungal invasion of the orbital apex and superior orbital fissure through the sphenoid, and also they may not have much of fungal bulk in the orbit. It may be direct involvement of the superior orbital fissure that results in a white eye with ophthalmoplegia. This patient has minimal proptosis, but she has complete ophthalmoplegia because of involvement of the orbital apex. CRAO is also one of the early symptoms, signs. And in stage 3C, we also have diffuse orbital involvement, as we see here. And stage 3D is bilateral. In stage 4, there is CNS involvement, either partly or completely involvement of the cavernous sinus, and sometimes it passes through the foramen rotundum, pterygopalatine fossa, foramen rotundum, and directly gets into the midbrain. Then patients present with bilateral third nerve palsy. This is one such example. This is brain infarction 4C, and this is diffuse CNS. This is 4D. In our study, we found that majority of patients presented at stage 3, which is the orbital involvement. So in diagnosis, microbiopsy of the nasal mucosa appears to have the best diagnostic yield, which means that in the clinic, you take a bit of the affected nasal mucosa under visualization. Endoscopy guided nasal mucosal swab also has equally good diagnostic accuracy. And for a quick diagnosis, you can rely on rapid histopathology such as splash and imprint cytology and frozen section, which can give you diagnosis in 15 minutes. Of course, we have microbiology, calculus white, and KOH mount as one of the standard ways of diagnosing. And in scanning, imaging is extremely important. CT scan lags behind. So what is important is to do a good MRI, and MRI signs have already been described. In the management, the first thing that we do is an RT-PCR. If the patient is positive, then you admit with all COVID precautions. If the patient is RT-PCR negative, then you admit in a critical care unit, but obviously without COVID precautions. Then if a patient has possible mucormycosis, where the patient has typical symptoms and signs in the clinical setting, that is less than 6 weeks after having been treated with COVID-19, with diabetes mellitus, immunosuppression, etc., then if the patient does not have any MRI or CT sign and nasal endoscopy shows normal mucosa, in that case, you still keep the patient under suspicion and observe every 24 hours for progression. If the patient responds to symptomatic treatment, then obviously mucormycosis is unlikely, but you continue to observe them for a prolonged period of time, that is 3 weeks. If a patient during observation develops any of the radiological or clinical signs, he goes into the category of probable mucormycosis. At the point of presentation itself, if the patient has symptoms as well as signs, which is radiological and clinical, then the patient is categorized as probable mucormycosis. Proven is when you have evidence by microbiology as well as or histopathology, then that is considered proven mucormycosis. In either of this, probable or proven, you're bound to start them on amphotericin B, preferably liposomal in full dose, which is 5 milligram per kg body weight. In the absence of liposomal amphotericin B, you can start them on deoxycholate or lipid complex, but we should realize that these are more nephrotoxic. If the patient has a compromised renal function, then you can consider posaconazole or isavuconazole as one of the options. After having started these patients on antifungals, which is the first step that you would take, you would prepare them for surgery. If a patient has predominantly sinus or sinonasal manifestation, then you do an early aggressive debridement of the paranasal sinuses by appropriate surgical approach. And for the minimal orbital component, you can give intraorbital amphotericin B, which is 3.5 milligram per ml of deoxycholate, and observe the patient very carefully. During observation, if the patient progresses to involve the orbit diffusely, or if there is worsening of the orbital component within 72 hours after having done debridement and started the patient on amphotericin B, then you may consider orbital exentration. If the disease is still limited at that stage, you may consider intraorbital amphotericin B. If a patient at the point of diagnosis itself has extensive orbital involvement, has PL negative eye with limited or no CNS disease, then you combine orbital exentration along with paranasal sinus debridement. If a patient has extensive CNS involvement, then our study has shown that despite having extensive CNS involvement, if you were to do orbital exentration, then the chance of survival is higher. So you may still want to do orbital exentration even in a patient who has extensive CNS involvement, provided the patient is fit for surgery. Then once you have given amphotericin and the patient has radiologically and clinically stabilized, then you consider step-down therapy with oral posaconazole or isavuconazole. This is just an example of orbital exentration. And this is a patient who did not need orbital exentration, was controlled just with paranasal sinus debridement and intraorbital amphotericin B. In our series, we found that these 41% of patients were definitely regressed and alive. 14% were obviously definitely dead. But in the middle, some of who were stable clinically with some residual disease and some are progressing, obviously they can shift to either of this. So we have.
Very sorry to interrupt, sir.
Okay, fine. I'm done with it. All right. So the conclusion is that we should moderate steroid use, control diabetes mellitus, and be aware of the red flag symptoms and signs. Barrier and hygiene are important. Appropriate ophthalmic and ENT consult if the patient has any of the red flag signs, and a high index of suspicions and combined efforts by a multidisciplinary team are important in ensuring survival.